Hi, my name is Dr. Liz Angelewski, and I'm the Director of Clinical Education and Training at Theralase. In this clinical education video, we will discuss Achilles tendinopathy, often referred to as Achilles tendinitis, condition that affects one of the largest tendons in the body, the Achilles tendon, causes pain in the back of the leg just above the heel. The Achilles tendon connects the calf muscles posteriorly to the calcaneus and is a commonly injured tendon. The commonly used term tendinitis is confusing because inflammation is often not seen on histopathology. Throughout this video, we will use the term tendinopathy to refer to pain associated with an Achilles tendon injury other than a tear or a rupture. Achilles tendinopathy affects professional and recreational athletes as well as people who are not active. Professional athletes have a lifetime incidence of 24%, with 18% sustained by athletes younger than 45 years. Among competitive runners, the lifetime incidence of Achilles tendinopathy may be as high as 40 to 50%. Achilles tendinopathy in recreational runners accounts for 6 to 17% of all running injuries. The Achilles tendon endures strain and risks injury from running, jumping, and sudden acceleration or deceleration seen in sports such as basketball and soccer. Acute Achilles tendon pain generally develops when athletes abruptly increase their activity, for example, runners who start training for a marathon. Chronic tendon pain may result from sustained stress, poor running mechanics, or improper footwear. Increasing age, male gender, and obesity are also risk factors for Achilles tendinopathy, and overuse or recurrent microtrauma, vascular disease, neuropathy, and rheumatologic diseases may cause degeneration of the Achilles tendon. Patients with Achilles tendinopathy typically complain of pain or stiffness 2 to 6 centimeters proximal to the insertion point of the Achilles tendon. They are likely to be recreational or professional athletes who have increased their training intensity or who have been training rigorously for a long time. The pain is usually described as burning and is worse with activity and relieved with rest. Examination of the Achilles tendon is usually straightforward because the tendon is easily identified and palpated. The patient lying prone, inspect the region of the Achilles tendon for bruising, swelling, and foot misalignment. Palpate the Achilles tendon for tenderness, thickening, or a defect. The presence of crepitus with dorsiflexion and plantarflexion of the foot is suggestive of tendinopathy. Examine the patient's shoes and look for signs of excessive breakdown, disproportionate wear on the inner or outer edge, or other evidence of poor running mechanics. Examine the patient's feet and look for the presence of flat feet, heel malalignment, high arches, or a leg length discrepancy. Also, assess the patient's gait or running stride and look for any abnormalities or asymmetries. Plain radiographs are generally not necessary in the assessment of Achilles tendon pathology except to rule out other conditions such as a fracture or a tendon rupture. Diagnostic ultrasound and an MRI may be used to assess tendon appearance and function and may reveal signs of tendon pathology. Ultrasound and MRI appear to be accurate tools for diagnosing Achilles tendon tear, distinguishing between partial and complete tears. Treatment of acute Achilles tendinopathy generally consists of rest and avoiding aggravating activities, applying ice when symptomatic. Conservative care using low-level laser therapy is useful in reducing pain during activity and supporting the Achilles tendon with a heel lift or taping. Chronic Achilles tendinopathy exists when pain persists beyond 3 months. In addition to the basic interventions for acute exacerbations discussed, treatment should include a rehabilitation program that emphasizes resistance exercises using heavy loads or exercises that emphasize the eccentric portion of exercise movements. Partial tendon tears and chronic tendinopathy that fail to improve with 3 to 6 months of conservative treatment may benefit from consultation with an orthopedic surgeon or a physical medicine and rehabilitation specialist. Prevention of re-injury is critical, as 10% of Achilles tendon ruptures occur in previously injured tendons. It is recommended that patients continue to perform their exercises once rehabilitation has been completed and symptoms have resolved. Several interventions may reduce the risk of developing new or recurrent Achilles tendinopathy. It's important to warm up before engaging in any exercise and avoid training in cold weather. Make sure appropriate shoes are worn and avoid running on hard surfaces. It is reasonable to include a stretching program either following exercise or during the warm-up phase. Stretching the gastrocnemius and soleus muscles may be beneficial. The Theralase TCL-2000 therapeutic laser is well indicated and very effective in treating Achilles tendinopathy. In a majority of cases, the pain is reduced after the first few treatments, with subsequent healing of affected tissues greatly accelerated. It is recommended to have the patient either lying prone with their feet hanging off the end of the examination table or have the patient kneel on a soft surface. Treat first directly over the mid-portion of the Achilles tendon, working your way up to the calf muscle. Treat the patient every day for the first 3 days, then 3 times a week thereafter. Treatment protocols are customized by the Theralase TCL-2000 automatically based on a patient's physical characteristics. Pain will continue to decrease and mobility will continue to increase with each subsequent treatment. For acute Achilles tendinopathy, an average of 5 to 10 treatments is recommended, and for chronic Achilles tendinopathy, an average of 20 to 30 treatments is recommended.